Hello, this is my machine learning lifecycle management project presentation. The problem that I'm looking to solve with this solution, this example for lifecycle management, is the high incidence and impact of strokes on people. Strokes are a very serious condition that can lead to severe health complications, disability, and death. And by looking to predict the likelihood of a person having a stroke based upon their demographics and health history. The aim here is to identify individuals at high risk, and this will allow health systems and providers to do proactive prevention strategies for those patients. This will allow timely interventions, personalized health plans, efficient resource allocation, and ultimately reduction in stroke occurrences across the health system and across our country. So can machine learning help solve it? I absolutely think it can. As far as feasibility goes, we've already seen, the industry has already seen machine learning used for predictive purposes for other health conditions across multiple diseases, um, diabetes being one example, heart disease being another example. So history shows that this is indeed feasible. As far as getting the data, my research has shown that there is reliable health data available in a variety of places online. Kaggle is a popular site where I was able to find some strong data sets that could help indicate, based upon comorbidities and other patient demographic and health information, that patients are at higher risk to have a stroke. Do people care? Does it matter? Absolutely. If you look at what I'm showing here, there's a number of different reasons why it matters. Prevention, improving outcomes for people, education and awareness so that people can understand that they're at risk and they can make behavioral and lifestyle changes. Also can help them understand what the comorbidities are. In other words, what are other diseases like that are seen along with people who are at risk for a stroke. And then they also have a personal impact on this because both my father and brother, my father's passed away from a stroke, and my brother had a very serious stroke. So there's something personal there that I want to help solve this. From a methodology perspective, we're going to be using the CRISP-DM process to approach this problem. And so we will look at kind of what the first thing we're going to look at is what is our understanding of the business need here. Who are our target users? We are targeting healthcare providers, and which would be health systems, both ambulatory and hospital. They will be the users to help target the patients that are at risk. And then individuals themselves who will be the ones that will be receiving the information that they are or are not at high risk of having a stroke in the future. What are the gaps in the current solution? Really, today, providers don't consistently screen for this or many other diseases for that matter. It's simply not efficient, nor is it part of the standard workflow. They're typically they really would not even start to consider this until the patient started showing symptoms that would potentially lead to stroke. Also, there's a high variability between physicians and health systems where prevention is a focus, and there may be prevention for other health conditions besides stroke. So the variability here is another gap in our current solution. So what's the definition of success for this? We expect to be able to increase the number of patients we can identify for at risk for stroke. We want to increase the awareness and the habits of people that are at risk. We want to provide more preventive and comprehensive care for patients. We want to increase the utilization of stroke prevention education programs. A lot of health systems have these programs out there. They're typically and oftentimes underutilized. So we want to make sure that we're taking full advantage of those programs. Also, we want to decrease the number of emergency visits for strokes. And all this really equates to decreasing the cost for patients, providers, and payers due to fewer stroke victims that have to be treated. The constraints we have is making sure that we have enough data volume to provide sufficient accuracy of predictions. We want to make sure we also incorporate these predictions into existing workflows of providers, health systems, and practice staff. And we also want to make sure that that there's a sufficient outreach, communication of the risk score and what it means to patients. The metrics we'll be tracking here, the outcome, we are going to be looking at the individual patient stroke risk scores across a given patient population or cohort. And the output, we'll use area under the rock for our predictions. Our targets, we want to look for outcome. 80% of the patients seen within the last 3 years have a stroke risk score. And then we'd like to see for an output, the AUC is greater than 0.8. What are the main and relevant factors that we're looking at that will help determine patient risk for having a stroke? The patient demographics, what's their health history look like, what's their family history look like, their social determinants of health, such as access to care, how far are they away from the nearest healthcare system, do they have transportation, and other sorts of social determinants that are high indicators of potentially other health issues. And then common comorbidities, in other words, what are the other conditions or diseases that they might have that may give them a higher chance of being at a higher risk to actually have a stroke. My validation plan here is the solution concept itself. The stroke predictor is going to evaluate a patient population and establish a stroke risk score for each patient. The stroke risk score will then be made available to the health system's reporting solution. In addition, we're also going to track to capture our key data points so that we can put together an explanation of the risk score for each patient, so they will understand how to interpret the risk score and also why they scored the way they did. The staff will periodically run these reports. This will also include the patient's info as well as their patient's key info as well as their contact info. And this will be supplied to the patients in whatever patient engagement channels that they currently use. And the solution will use machine learning by ingesting this key historical information about each patient. It will use a classification model, and it will output a target risk score that we'll then use in our final solution. So how will I validate the proposed solution? We will establish and deploy our machine learning model using what we utilized in the course 1. We will gather historical patient data, analyze it to see what patterns emerge. This will help us also find which features would be most relevant. Now we'll, of course, split our data for training and testing. We will evaluate our numerous models to find out which ones provide optimal output metrics. We will evaluate the performance of the test data, making adjustments. We'll select our model and we'll deploy it to make it available for reporting solutions. Now, how we iteratively check this, we're going to use sample client data to output simple spreadsheets. We will then work with the clients to evaluate the results and incorporate feedback back into our model. Also, during this process, we will identify key report options such as filters, report fields, automated schedules, and how the report itself will be run to be optimal. And then once we've reached our acceptable level of accuracy, we are ready to build build out the new report as well as deploy our first production version of the model. We'll then build and deploy the reporting solution, including integrating our model into the reporting solution. And then we'll have it available for the users to run reports whenever they see fit. And they'll be able to then run this periodically, communicate to the patients. We will monitor the performance, and then we'll iteratively update the model and report options based upon user and patient feedback. From a design perspective, the decisions here that we're looking at are pretty straightforward. Cloud or edge, we would want to use the cloud design for this particular solution. All the computations and report prep are done on the back end environment. We've got network connectivity, so that's not an issue. These are batch reports that are run periodically, so also low latency is not a concern. And then the patient data itself has already been granted, the patient's already granted permission for the health systems to use the data for medical purposes. So we've got the permission, and the data is already actually stored in the cloud, so no issues there with the transmission. As far as offline learning or online learning, again, this is pretty straightforward. We'll use offline learning. As we mentioned, this is a batch approach on reports, and it's not something that would be online. Furthermore, there is no actually online learning from the patients directly. And the model retraining will also be done periodically using data points across many iterations as the patient population grows and changes. And we will use batch predictions over online predictions. Again, this is straightforward since we're running things in batch. We'll do batch predictions. We'll periodically schedule these and communicate them to the patients. When there's new data that comes in, it's going to take a while for that data to come in and for new patients. And so it's not necessary nor probably even useful to provide immediate recommendations. We're going to need a bit more data to come in. And also we can easily identify and react to model drift with each run of the report. As far as potential risks go, there may be a potential training serving skew risk due to the availability of the feature data elements across all the patients as well as various clients. It all depends upon the data capture that the clients have done across many of these important elements such as comorbidities, and make sure that they've asked all the health history questions and they have answers. So we may run into that. I do not expect any data or concept drift since the idea of key factors for patients that are at risk of stroke are very well documented and established in the medical community. So I think we'll be pretty good on data, on not having any data or concept drift. And then finally, just as a kind of a aside, the data sources that we would look to use would be data science data sets, health system data sets, electronic medical records, and medical references. These would all go into what we would consider for both our training and test data sets. Thank you for your time today. I look forward to your feedback and comments.